You know, usually when we think about a modern city, we just see what's on the surface,
Yeah.
like the paved roads, the glass skyscrapers, manicured parks. We assume that what we're looking at is, all that's there.
Right, but if you actually dig down, you find the old brick foundations, the forgotten subway tunnels, rerouted underground rivers even.
Exactly. The surface looks perfectly normal, but the underground landscape has been completely terraformed by its history.
It's a completely different world down there.
And that is the exact reality inside the human body when you survive certain types of cancer.
Mm.
The outside looks completely healed, but the internal landscape
Mm.
has been fundamentally rewritten.
Yeah, that's a really great way to put it.
So today we are doing a deep dive into the hidden lifelong legacy of a highly intense medical procedure, specifically pelvic brachytherapy.
Right.
We're pulling from this incredibly diverse stack of sources. We've got clinical guidelines from NICE, the BGCS, AUGS, plus patient informational guides from MD Anderson and Cancer Research UK.
And we also have some rare, highly specific surgical case reports to look at.
Yes, which are fascinating. Our mission today is to explore how a patient's history of brachytherapy fundamentally alters their internal anatomy.
Right, and to answer the critical question of how this brachytherapy history dictates the planning of literally any future medical treatments they might need.
Exactly. And whether you're a medical learner or maybe you're supporting a loved one through treatment or just someone who is fascinated by how the human body adapts and heals, this deep dive is going to reveal the hidden long-term legacy of surviving cancer.
It really is incredible what the body goes through.
So to understand that long-term legacy, we need to first look at how this treatment physically interacts with the body. Because, most of us picture external beam radiation when we think of cancer treatment.
Yeah, standard radiotherapy. You're lying on a table, and a massive machine is aiming these invisible beams through your skin to hit a target deep inside.
Right.
But in doing so, that beam has to pass through healthy tissue to get there.
Which obviously causes damage along the way.
Exactly. Brachytherapy, which is heavily used for vaginal, cervical, and uterine cancers, flips that entire approach. It is internal radiation.
Internal.
Right. So instead of beaming it through the body, the medical team places the radioactive source right against or even directly inside the tumor itself.
Okay. And the patient guides, we looked at detailed two main delivery methods for this.
There's intracavitary and interstitial.
Right. So intracavitary brachytherapy uses these smooth, plastic, cylinder-shaped applicators that are placed inside the vagina.
Yeah.
But then there's interstitial brachytherapy, which involves placing narrow tubes or actual needles directly into the tumor or into the vaginal wall under anesthesia.
And the treatment planning process for this is it's a marvel of physics and anatomy.
Oh, I bet.
Once those applicators or those needles are clamped securely into position, the patient actually undergoes CT or MRI scans with all this hardware inside them.
That sounds so intense.
It is. The oncologists and medical physicists use those scans to map out the exact required radiation dose, like down to the millimeter.
And the delivery itself sounds honestly like science fiction.
It really does.
You're alone in a thick-walled room, and a tiny radioactive pellet on the end of a wire travels from a machine through a tube directly into that applicator inside you.
Right.
It just sits there delivering a massive, highly localized dose for a few minutes, and then the wire pulls the pellet back into the machine.
Yeah, and patients are understandably terrified that they'll be, glowing in the dark afterward.
Oh, for sure.
But because the radioactive source retracts, the patient is entirely safe to be around others, even children, literally the second that machine clicks off.
Wow.
The radiation doesn't linger in their body, but the biological effects of the radiation do.
So if external beam radiation is kind of like crop dusting an entire yard to kill a weed, this brachytherapy is like precision bombing that weed from directly underneath the soil.
That's a perfect analogy. And the reason that extreme precision is so necessary is because of the fall-off.
The fall-off.
Yeah, the radiation dose drops dramatically, mere millimeters away from the source. It is designed to physically shatter the DNA strands within the cancer cells so they can't replicate.
Okay.
All while sparing as much of the surrounding neighborhood as possible.
Wait, I'm actually stuck on something here.
Okay, what is it?
You just said this is like precision bombing right at the source with this steep fall-off to spare the neighborhood.
Right.
If this treatment is so incredibly localized and targeted to the tumor, why do the patient guides list this massive range of collateral damage? Like, it seems like a huge contradiction to me.
I get why that seems contradictory. But it really comes down to real estate.
Real estate.
The pelvis is incredibly crowded. You have the bladder, the rectum, the vagina, the uterus, the intestines. They are all tightly packed together, physically resting against one another.
Ah, I see.
So even with a steep fall off, any tissue that is immediately touching that cylinder or those needles gets hit with a massive, significant dose of radiation. It sets off a whole chain reaction.
So the immediate fallout really is brutal. The guides list severe diarrhea, profound fatigue like just getting out of bed is a monumental task,
Yeah.
and radiation cystitis.
Radiation cystitis is actually a perfect example of that collateral damage.
How so?
Well, the radiation severely inflames the inner lining of the bladder. The tissue swells up, creating this burning sensation and an agonizing constant urge to urinate, even when the bladder is completely empty.
Oh, wow, that sounds awful.
It is. The cellular lining simply can't function properly.
But those are just the acute phases, right? The short-term effects.
Correct.
The real terraforming, like the permanent structural changes to the internal landscape, that starts happening as the body tries to heal.
Exactly. Because the radiation permanently damages the healthy tissue's ability to regenerate.
The sources mentioned it can cause early menopause if the ovaries are affected, right?
Yes, absolutely. But it also triggers a process called fibrosis in the irradiated areas.
Fibrosis. What exactly is happening there?
Normally, when tissue repairs itself, it lays down collagen in a neat, organized way to maintain elasticity. But radiation throws that healing process into a state of chronic, disorganized panic.
Okay.
Instead of soft, pliable tissue, the body lays down dense, rigid collagen fibers. The healthy tissue in the vagina is essentially replaced by scar tissue.
Wow.
The vagina literally becomes shorter, narrower, and loses its elasticity entirely.
It's just a brutal irony. Like, you survive cancer, but your tissue is essentially scarring over and shrinking in the process.
Yeah.
So because of this, the treatment planning immediately adapts post-radiation. The medical team has to prescribe these plastic cone-shaped vaginal dilators.
Right, usually starting 2 to 8 weeks post-treatment.
And the patient has to actively, mechanically stretch their own healing tissue.
They do, and the reason why is that without that mechanical stretching, the newly forming collagen bonds in that fibrotic tissue will contract and harden.
And what happens if they don't do it?
The vaginal walls can literally stick together and fuse completely.
Oh my God.
It's a condition called adhesions. And if that happens, future pelvic exams, which are critical for monitoring for cancer recurrence, become impossible.
Right. They can't even get in there to check if the cancer is back.
Exactly. Not to mention that sexual intercourse would become agonizingly painful.
Imagine going through the physical trauma of cancer treatment and then being told your so-called recovery involves a strict, prescribed regimen of stretching your tissues with plastic cylinders just to maintain basic anatomical function.
It's an immense physical and emotional burden.
But as profound as those changes are, they don't stop once that immediate recovery phase ends, right?
Not at all. That chronic scarring doesn't just stabilize.
Right, when history catches up. The case reports were looking at detailed, severe complications emerging decades later.
Yes, decades.
This is where we really answer our core question.
Yeah.
Yes, a brachytherapy history completely rewrites the standard surgical playbook.
It absolutely does, because radiation damage is progressive. The underlying mechanism here is a pathological process called endarteritis obliterans.
Endarteritis obliterans. Okay, so explain that. Let's think of the micro blood vessels in the pelvis, like a highly efficient network of supply highways, right?
I love that analogy, yes. So the endothelial cells, which are the inner walls of those highways, to swell, scar, and eventually collapse entirely.
So the roads are blocked.
Exactly. Over the years, the tissue is slowly starved because the supply trucks carrying blood and oxygen can no longer get through.
And without blood and oxygen?
The tissue loses its ability to heal entirely. It's chronic necrosis.
And that chronic starvation of blood doesn't just stop things from healing. The sources say over decades that dead tissue literally starts to give way.
It collapses.
Right, and creates holes between organs that should never be connected.
Yeah, radiation-induced fistulas.
Which brings us to the first highly specific case report in our stack. This involves a 46-year-old woman treated for stage IVA cervical cancer. She had chemotherapy and interstitial brachytherapy, and years later, she developed synchronous vesicovaginal and ureterovaginal fistulas.
To visualize that anatomy, she had holes formed simultaneously between her bladder and her vagina, and between her ureters and her vagina.
Wait, her ureters? The tubes from the kidneys?
Yes, so she was experiencing continuous, uncontrollable urine leakage directly through her vagina.
Her quality of life must have just completely plummeted.
Unimaginably so.
Now, standard surgical protocol for a fistula is to go in, cut out the damaged edges, and sew the healthy tissue back together.
That's a normal playbook.
But they couldn't do that here.
No. Because of that endarteritis obliterans, there was zero healthy tissue. If a surgeon tried to stitch those irradiated blood-starved tissues together, the stitches would just tear right through the necrotic tissue.
Because it's too weak.
It's literally like trying to sew wet tissue paper. Her history completely forced the surgeon's hand.
They had to abandon a local repair entirely.
Right. They had to perform an ileal conduit.
Meaning they had to permanently divert her urine to a stoma, a bag attached to the outside of her abdomen, simply because her internal tissues were too fragile to ever be repaired.
The radiation cured her cancer, but it permanently altered her biological capacity for surgery.
So the radiation damage is basically a ticking clock.
In many ways, yes.
The tissues permanently lose their ability to heal, meaning if you need surgery 20 years later for something entirely unrelated, the surgeon has to throw out their standard playbook and build a new one.
You nailed it.
Yeah.
And the second case report we have is a perfect example of just how inventive surgeons have to be to work around this terraformed landscape.
Oh, this one was wild. We have a 58-year-old woman who suffered an emergency colon perforation.
But the defining factor in her operating room wasn't the emergency perforation itself.
Right. It was the fact that she had received pelvic radiation 20 years prior for Hodgkin's lymphoma.
2 decades later, that radiation history was still the loudest voice in the room, dictating her care.
So what happened?
Well, following her emergency surgery, she developed a rectovaginal fistula, a hole between her rectum and vagina.
And again, stitching the hole closed was impossible.
Right. The irradiated tissue would just disintegrate. They couldn't use the local tissue because it was basically a blood-starved wasteland.
So to fix her, the surgeons had to invent an entirely new anatomical route specifically to avoid using radiated tissue.
Exactly. They utilized what's called a Tuttle transvaginal access and a Turnbull catate colon pull-through.
Which means?
It means they had to pull healthy, non-radiated colon, the descending colon, from much higher up in the abdomen, pulling it all the way down through the pelvis to create a new connection.
That is so extreme, but even that wasn't enough, right?
No, it wasn't enough to close the vaginal side of the hole.
They actually had to use a Singapore flap. They harvested a patch of tissue from her thigh, complete with its own healthy blood vessels, and grafted it into the pelvis.
They literally had to import fresh blood supply from her leg into the pelvic wasteland just to make the repair survive.
If you are a surgeon, a patient's history of pelvic radiation is a giant, flashing red flag.
You cannot treat their anatomy like standard anatomy. You have to operate under the assumption that the tissue is entirely hostile to healing.
Which brings up a really huge dilemma. If the tissue is that fragile and blood-starved, how do doctors even begin to treat the severe genitourinary syndrome of menopause, or GSM, that the radiation itself causes?
That's a huge challenge
Yeah.
because, as we mentioned, the radiation doesn't just scar the vagina. If it hits the ovaries, it throws the patient into sudden early menopause.
Right, and the patient's history complicates everything about treating those menopausal symptoms. It leads to a deeply divided medical consensus.
Let's look at the hormone replacement therapy debate first, HRT. For a long time, the blanket assumption was that giving estrogen to a cancer survivor was like handing out free building materials to a tumor that's trying to rebuild itself.
Right, the fear was that the hormones would somehow wake up any dormant cancer cells.
But the clinical guidelines from the British Gynecological Cancer Society, the BGCS, actively push back on this assumption.
Really?
Yes. For cervical and vaginal cancers, they state that HRT is actually heavily recommended post-pelvic radiotherapy.
Wow. Recommended.
Yeah, it significantly reduces vaginal toxicity, and it prevents the severe pelvic fractures caused by radiation weakening the bones.
But the prescribing is heavily dictated by what anatomy the patient still has, right?
Exactly. If they had a hysterectomy and their uterus was surgically removed, they get estrogen-only HRT.
Okay.
But if they have an intact uterus that was blasted with radiation, they must use continuous combined HRT, meaning estrogen and progesterone.
And the biological reason for that specific combination is wild to me. The sources say functional uterine lining can surprisingly persist even after high-dose radiation.
It's incredibly resilient. So if you give them unopposed estrogen, it could trigger the growth of a brand new endometrial cancer.
But the guidelines also note that low-dose topical vaginal estrogen is generally safe.
Yes, the systemic absorption from a topical cream is minuscule.
But what if a patient absolutely cannot or will not take hormones? Say a breast cancer survivor who is on estrogen-blocking drugs but still needs relief from the severe vaginal atrophy.
And that brings us to the laser therapy debate. We are talking about energy-based devices, or EBDs.
Like fractional CO2 and ERYAG lasers.
Right. The theory behind these energy-based devices is that by firing lasers into the vaginal wall, you create controlled micro-injuries.
Micro-injuries.
Yeah. Heating the tissue to a specific degree is supposed to stimulate the body's natural healing cascade, forcing it to produce new collagen and essentially reverse the atrophy.
Okay, I am really struggling to wrap my head around the logic
It's like
here.
blaming you.
We just established that this tissue is completely starved of blood, heavily fibrotic, and has zero capacity to heal itself, to the point where surgeons have to import thigh tissue just to close a wound. It sounds like a double-edged sword. We have this incredibly fragile, previously irradiated tissue, and the proposed solution is to fire more lasers at it.
To intentionally cause more damage, essentially.
Right. Even when the gold standard of clinical trial suggests the benefits might just be an expensive placebo effect.
The clinical literature completely validates your skepticism here. The medical community is deeply fractured over this.
What do the different sides say?
Well, on one side, reports from groups like AUGS and NICE highlight some observational studies where patients report short-term improvements in dryness and pain after laser treatments.
But on the other side, you look at the FDA's MUDE database, which tracks adverse medical events, and it reads like a horror story.
It really does. We're talking about severe scarring, third-degree burns, worsening pain during intercourse.
And even devastating vaginal lacerations when patients tried to resume intimacy after the laser treatment.
Yeah, the complications are severe. But the most definitive answer in this debate comes from a rigorously designed, JAMA randomized clinical trial.
Okay, tell us about that one.
They specifically studied breast cancer survivors who were on aromatase inhibitors, drugs that completely wipe out the body's estrogen, who were suffering from severe GSM. They randomized the women into two groups. One received the fractional carbon dioxide laser therapy. The other group received a sham treatment.
Wait, a sham treatment, like a placebo laser?
Exactly. They inserted the probe but never actually turned the laser on.
Oh, wow. And what were the results?
The biological results were damning. The actual laser therapy was no more effective than the sham treatment at improving symptoms.
No more effective than a turned-off machine.
Right. In fact, the actual laser treatment was tolerated worse by the patients. Both groups saw some subjective improvement, which really just points to a massive placebo effect.
Just from participating in a clinical trial and getting, empathetic medical care.
Exactly. But the laser itself provided no superior biological benefit.
Cancer survivors are just desperate for relief from these brutal, life-altering symptoms. And that desperation makes them incredibly vulnerable to these expensive, highly marketed, innovative laser therapies.
It's a really difficult position for patients to be in. The long-term safety of firing lasers at already irradiated fibrotic tissue remains completely unknown.
So medicine is constantly struggling to safely manage the long-term damage that life-saving treatments leave behind.
Absolutely.
What we've uncovered today is that the journey of brachytherapy begins with a singular, incredibly precise delivery of internal radiation.
But that single event ripples outward for the rest of the patient's life.
Exactly. It causes these profound anatomical changes like fibrosis that demand daily, painful mechanical intervention. It fundamentally alters the surgical playbook for any future operations for decades to come.
Right, forcing surgeons to invent new approaches.
And it vastly complicates the management of aging and menopause, leaving doctors debating the safety of hormones and lasers.
It really highlights that understanding a patient's medical history isn't just about reading a diagnosis on a chart.
No, it's about recognizing how past medical interventions permanently terraform their biological landscape.
And that terraforming is irreversible.
Which leaves us with a lingering thought to mull over today. Consider this concept of biological cost.
Biological cost.
Yeah. Modern medical technology miraculously allows us to survive previously fatal cancers, right?
Thank goodness for that.
But are we truly prepared as a medical system and as a society for the reality that the cure often creates an entirely new, deeply chronic condition?
That's the real question.
As we look to the future of oncology, how will the next generation of targeted cancer therapies learn to clean up the permanent footprints they leave behind?
Because right now, long after the tumor has been eradicated, that terraformed underground city remains.
It is a heavy, lifelong cost for survival. Thanks for joining us on this deep dive today.